expect in this patient? Yes, very good. It is cortical vein thrombosis. And in cortical vein thrombosis, you will get a triangle here. Okay, a triangle here. What is this triangle called as? Called as empty delta sign. Yes, you get empty delta sign. Okay, and you also get one more thing here, which is going to be like this. What is this called as? It is called as dense cord sign. Dense cord sign. So two signs you are going to get in the imaging. Okay, empty delta sign and dense cord sign. Okay, so if you are going to know this, then it is going to be easy. What is this one? What is this one? This is the empty delta sign, and this is the dense cord sign. So empty delta sign and dense cord sign you are going to get in cortical vein thrombosis. Cortical vein thrombosis. So I hope I'm clear with the image. Okay, clear with the image. Okay, then moving on to the next topic. Okay, the next topic is the recently asked question. Okay, the blood pressure target during acute stroke. Okay, so blood pressure control. What is the relevance of blood pressure in stroke? Okay, so here I am going to again tell you, whenever a patient is having stroke, okay, the blood pressure is always very, very important, because in patients with stroke, what happens? There is a process which happens in our body called as autoregulation, which tries to maintain the map between 50 to 150 millimeter of mercury, so that there is going to be perfusion. Okay, and we all know that the cerebral perfusion pressure is equal to, it is equal to map minus intracranial pressure. Okay, so to maintain the cerebral perfusion, our body will try to increase the map. And inadvertently, if you're trying to reduce the BP, then what will happen? The cerebral perfusion decreases. Okay, so there are certain indications where you are going to decrease the BP. Whenever you plan for IV thrombolysis, okay, and whenever you are going to plan for thrombectomy, then you try to keep your BP less than 185 by 110 millimeter of mercury. And whenever you don't plan for these things, okay, you're not going to plan anything, you're going to go for conservative management, then you keep your BP less than 220 by 120 millimeter of mercury. Okay, 220 by 120 millimeter of mercury. Very good. Okay, 220 by 120 millimeter of mercury. Okay, so how you are going to plan the treatment? Okay, so whenever you have any patient with stroke is coming to you, you first see for the features are suggestive of stroke. Then the second step is you go for the non-contrast CT, and the third step is you are going to see what is the duration of weakness. Okay, whenever the duration of weakness is less than 4.5 hours, what I'm going to do, whenever it is more than 4.5 hours but less than 24 hours, what you're going to do, whenever it is more than 24 hours, what you're going to do. So three things you're going to decide. Three things you're going to decide. Okay, whenever it is less than 4.5 hours, it is called as the golden period, right? Golden period. So during this golden period or the window period, what you're going to do is you're going to plan for thrombolysis. Okay, thrombolysis. How you are going to plan thrombolysis? You are going to go for IV recombinant tissue plasminogen activator, and the drug is going to be alteplase, right? If it is not uh, fruitful, if it is not effective, then you can go for mechanical thrombectomy. Mechanical thrombectomy, right? I have told you this in our regular class. Whenever it is within 24 hours, okay, and usually less than 6 hours, okay, usually less than 6 hours, then what you can go for is you can directly go for mechanical thrombectomy, and you should not go for thrombolysis. Okay, you should not go for thrombolysis. Okay, you should not go for thrombolysis. Okay, and if it is going to be more than 24 hours, then most of the time it is going to be conservative treatment. And what you're going to do, you're going to start on aspirin. Aspirin. So recombinant tissue plasminogen activator. Yes, RTPA is recombinant tissue plasminogen activator. Okay, so this is how you will approach a patient with stroke. Okay, and what are the indications and contraindications of stroke? So if you know from our regular class, we have discussed on table contraindication or at present contraindication and past history contraindication. So I have consolidated those things. Okay, so what is the contraindication? If you take the contraindication of stroke, then it is going to be patient is having head trauma in last 3 months, stroke in last 3 months, anytime hemorrhage, any active bleeding, heparin in last 2 days, hypoglycemia, and even I told sugars more than 400. Okay, whenever it is going to be involving more than 2/3 of the hemisphere, and platelet count less than 1 lakhs. Okay, 1 lakh, and patient has undergone any surgery or trauma. Okay, any surgery or trauma in last 14 days, patient had any hemorrhage in the last 21 days, and MI in last 3 months, all are contraindication. Okay, what is the indication? Okay, 24 hours, yeah, you go for thrombectomy, mechanical thrombectomy. Okay, mechanical thrombectomy. Okay, and what is the indication? So I told you indication is CAT. What is CAT? What is CAT? The patient is having clinical features, okay, and usually less than 4.5 hours. Okay, 5 hours. Age of the patient greater than 18 years of age. Okay, and next is patient having another C you can include here. Another C is patient is having CT scan showing 1/3 to 2/3 of territory. Okay, 1/3 to 2/3 of territory. Okay, and next is T is going to be you have to do total control of BP if you are planning for thrombolysis, which should be less than 185 by 110. You can include the T for timing also, time or duration. Okay, anyway, you can include. Okay, so these are the contraindications and indications for your patient being put on thrombolysis. Okay, always remember this, very, very important. So one thing you have to remember here is hemorrhagic stroke anytime in past is a contraindication. Contraindication. Okay, very, very important. Okay, very, very important. Coming to the next topic, which is going to be another one important topic in recent year, is going to be Lacuna stroke. Lacuna stroke. Okay, so what is Lacuna stroke? Lacuna stroke is a stroke which involves the small perforating branches or small arteries, okay, which are going to supply the deeper structures. Okay, why it occurs? It is occurs in patients with hypertension and old age. So what are the risk factors? It is going to be lipohyalinosis. Lipohyalinosis. Okay, lipohyalinosis, which is going to involve very small arteries causing areas of infarct which are going to be around 2 millimeter to 3 millimeter. Okay, and it is due to lipohyalinosis. It is going to be divided as a pure motor stroke. Okay, pure motor stroke. Okay, which is going to be having lesion in the internal capsule. Then next is pure sensory, which is going to involve the ventroposterolateral part of your thalamus. Then ataxic hemiparesis, which is going to involve the internal capsule and basis pontus, and dysarthria clumsy hand syndrome, which is going to involve the basis pontus. Okay, basis pontus. Okay, and one more thing here is which is going to be called as watershed infarct. Okay, watershed infarct. Watershed infarct is if this is the brain of the patient, we all know this territory is going to be your ACA territory. This territory is going to be your MCA territory. And this territory is going to be the PCA territory. Here, if I am going to consider this area, okay, this area, the border area is going to be called as the watershed area. And this watershed area where whenever a patient undergoes, for example, CPR, okay, during CPR, what is going to happen is this watershed area is not going to get blood flow. Okay, and it is commonly affected here. And because of this, what is going to happen is the patient is going to have features of stroke, and lacunar stroke features can occur in this patient. Okay, so why this happens? Whenever there is a patient is in shock, and because of shock, what you're going to do, you're going to go for CPR, and in CPR, the patient is going to have decreased perfusion over the border area, which is going to be called as your watershed infarct. Okay, watershed infarct. Okay, and this has been very important thing in your exam, because lot of times they have asked questions. We have discussed in our regular class also. Whenever you read the question, think what kind of symptoms they have given. If they give patient had weakness alone in upper limb and lower limb without any sensory involvement, then it is going to be pure motor. Patient has sensory involvement in the form of hemi anesthesia, then it is going to be pure sensory. Patient is having what is a wide based gait, reeling gait, patient is having frequent falls, then it is going to be again your ataxic hemiparesis. Then patient can have difficulty in using the hand, so clumsy hand, dysarthria clumsy hand syndrome. So these things are going to be few clues which will be given in your questions to identify lacunar stroke, where the pathology is very small and the clinical feature is also not so great. Okay, so this is about your lacunar stroke. Then next is localization of the stroke. Okay, so localization of the stroke is again a very vital topic. We have done and dusted with this topic during our regular discussion. Okay, so just for your understanding, I'm going to draw the circle of Willis. Circle of Willis. Okay, so circle of Willis, our favorite circle, where we are going to have a trunk, a leg, a limb, a ear, a horn. Right? This is our circle of Willis. This is going to be two vertebral arteries which join together to form the basilar artery. And here we are going to have the posterior cerebral artery. We have our internal carotid artery, anterior cerebral artery. This part is going to be your anterior communicating artery. Anterior communicating artery. And here we are going to have the posterior communicating artery. Okay, and this is going to be internal carotid artery. From internal carotid artery, one artery is going to go away, which is going to be your MCA. If I'm going to superimpose the brain on this, how the brain is going to get superimposed here? The brain is going to get superimposed like this. So we have two hemispheres. Okay, so I'm going to put two hemisphere here. Okay, two hemispheres here, and this is going to form the brainstem. Okay, this is going to be your midbrain. This is going to be your pons, and this is going to be your medulla. Okay, and from here we are going to have two arteries which are going to join to form anterior spinal artery. One artery which goes like this, which is going to be your pica, and branches of basilar artery is going to be superior cerebellar artery. Then we have pontine artery, then ica. Clear? Yes, yes, clear. Now, is there any lagging here? Any lag you face? Do you face any lag? No. Okay, no lagging is there, right? Okay. So now this is going to be the thing. So as you know, I am going to divide this further like this. This is going to be the ACA territory. This is going to be the MCA territory. Okay, so this is going to be your ACA territory. This is going to be your MCA territory. And this is going to be your PCA territory. Right? Okay, so this is going to be this thing. So now what I'm going to do is I'm going to superimpose the person. Right? So now you are able to understand here. So whenever you have, this is the thing, this is grossly have put everything inside one place. Okay, so what this one is indicating, this is going to indicate that this is lower limb. Okay, this is hand, this is the face, right? Okay, now if you have the leg involvement, then it is going to be ACA territory. Okay, so if you are going to have the face and the hand involvement or upper limb involvement, then it is going to be MCA territory. Whenever it is the vocal cords, whenever it is going to involve the throat, whenever it is going to involve the swallowing apparatus, then it is going to be your PCA territory. Hope I am clear here, right? So coming to here, whenever you have ACA territory involvement, okay, it is going to be A2 segment, which is going to be involved more commonly than A1 segment. Okay, so what is the clinical feature I have told you? Lisbra clinical feature. What is the Lisbra clinical feature? L for lower limb involvement, then S for social behavior, then R for release of reflexes, primitive reflexes. Okay, A for apraxic gait and abulia. Right? So this is going to be our clinical features. Okay, whenever ACA territory is getting involved, which I have told you, recurrent artery of Hubner. Okay, so it is going to be lower limb involvement, social behavior loss, then patient is going to have release of primitive reflexes, then abulia and apraxic gait. Okay, clear? Okay, then next is MCA territory is getting involved. Whenever MCA territory is getting involved, we have two segments here. MCA is going to have a M1 segment, and then we have going to have a M2 segment. M2 segment is going to have a superior division, inferior division, right? Okay, whenever you have M1 segment is getting involved, then what is the clinical feature? Someone can tell me what clinical feature patient is going to have, which we call it as some person from WWF. Okay, so it is going to be triple H. Okay, what is the triple H? Patient is going to have hemiparesis, hemisensory loss, homonymous hemianopia with facial nerve palsy with Parkinson-like feature. Parkinson-like feature. Okay, whenever superior division is getting involved, then it is going to be Broca's aphasia, right? And inferior division is going to get involved. Wernicke's aphasia, yes. Triple H's, hemiparesis, hemianesthesia, and homonymous hemianopia, right? Clear? Whenever M2 segment is getting involved totally, patient is going to develop global aphasia. Global aphasia. But specifically, superior division is going to supply which part? It is going to supply the inferior frontal gyrus. So it is going to be Broca's aphasia. And yeah, this part of M2 segment is going to supply the superior temporal gyrus. So it is going to be Wernicke's aphasia. Clear? Any doubt here? I hope no doubt here, right? So this is going to be the M2 segment. Okay, M2 segment and M1 segment. Then next is PCA is getting involved. Whenever PCA is getting involved, it is posterior cerebral artery. It is going to have two segments, P1 segment and P2 segment, right? Clear? P1 segment is going to supply the thalamus. So whenever P1 segment is going to get involved, what is going to happen? What syndrome patient is going to develop? He is going to develop thalamic Dejerine-Roussy syndrome. This is leg involvement, social behavior, release of primitive reflexes, okay, then abulia and apraxic gait, okay, apraxic gait. Apraxic gait. Yes. Okay. So Dejerine-Roussy syndrome. Dejerine-Roussy syndrome. What happens in Dejerine-Roussy syndrome? The patient will initially have hemisensory loss followed by excruciating pain. Yes. And P1 segment involvement, then you're going to have midbrain syndromes. What are the midbrain syndromes we are going to have? We are going to discuss it later also. Weber syndrome. Yes. Then we are going to have Claudy syndrome. Then Northern-Nagel syndrome. Then Benedict syndrome. Yes. Okay. Whenever your P2 is getting involved, P2 is going to supply which part? Medial temporal lobe and occipital lobe. Whenever medial temporal lobe is getting involved, what is going to happen? Patient is going to have memory loss. Okay. Whenever occipital lobe is getting involved, patient is going to develop what? What is called this? What is this one? So you are going to tell me. You are going to tell me. What is this? Homonymous hemianopia. Okay. Yes. Whenever your thalamus is getting involved due to P1 segment involvement of your PCA, then you are going to have thalamic Dejerine-Roussy syndrome. Okay. So this is homonymous hemianopia with macular sparing. And one more thing is here. What is this? Which is going to differentiate this from a parietal lobe condition when P2 is getting involved. Alexia without agraphia. Alexia without agraphia, right? Alexia without agraphia. Okay. Then whenever you have bilateral P2 involvement, bilateral P2 involvement, what are the two syndromes you are going to get? It is going to be Anton syndrome. What is Anton syndrome? Patient is going to have cortical blindness. Then another syndrome is Balin syndrome. What is Balin syndrome? Patient is going to have simultagnosia, optic ataxia, Oculomotor apraxia and polynopsia, right? Polynopsia. So these are the two syndromes you get to see here. Okay. Then coming to your posterior circulation, okay, which is going to be involving the basilar artery and vertebral artery. I will discuss it later. Okay, I will discuss it later. Okay, so here I will discuss only two syndromes here. One is Raymond-Cheston syndrome. What is Raymond-Cheston syndrome? It is sixth nerve ipsilateral with contralateral hemiparesis, right? Sixth nerve ipsilateral with contralateral hemiparesis. Then another one is your Millard-Gubler syndrome. What is this Millard-Gubler syndrome? Millard-Gubler is ipsilateral sixth nerve, seventh nerve with contralateral hemiparesis. Then the next one is going to be your Fovili syndrome. What is Fovili? Fovili is our facial nerve palsy with, what is this gaze palsy I used to tell you? Horizontal gaze palsy with weakness. Okay, that is called as Fovili syndrome, right? Fovili syndrome. Whenever a patient has bilateral sixth nerve, seventh nerve, MLF, PPRF, and corticospinal tract, what syndrome you are going to develop? Very good, excellent. It is going to be locked-in syndrome. Locked-in syndrome, right? So locked-in syndrome, the only movement possible in this patient is? Upward eye movement plus normal reticular activating system. So patient is aware of whatever is happening around him. That is going to be your locked-in syndrome. So you know that Anand character in Vasul Raja MBBS, right? Anand character in Vasul Raja MBBS. So this is about the, in a short, we have discussed all the arterial territories getting involved in your neurology. Okay. Then coming to the next thing is, we have discussed about lot of things in lobes of the brain. Fovili syndrome. Okay. Fovili syndrome is facial nerve palsy plus horizontal gaze palsy. Horizontal gaze palsy means you all know that it is going to be involving both the eyes when they look towards one direction. Okay. Then V for, it's a short form for weakness. V is weakness. Okay. Balance syndrome. Balance syndrome I have discussed already, right? We have discussed in and out that balance syndrome. S for simultagnosia. OA for optic ataxia, oculomotor apraxia, and P for polynopsia. Yes. Dr. Vignesh, what is required for vertical eye movements? Which part of the brain is for vertical eye movements? So from our previous discussion, vertical eye movements is by midbrain, right? That is rostral interstitial MLF part. Okay. So that is for vertical eye movements. For horizontal eye movements, we have MLF and PPRF in pons, right? So that is why we get here horizontal gaze palsy. Okay. And in locked-in syndrome, yeah, very good. Interstitial nucleus of Kajal. Very good. Super. So you remember things, right? Very good. That is very, very good thing to hear. Okay. Okay. So now coming to the next picture. Okay. Next picture. So what is this area? What is this area? of brain? Which lobe and area? Which lobe and area? Oh, very good. This area is angular gyrus in parietal lobe. And this parietal lobe is going to be on the left side. This picture, imagine it is going to be in the left side and it is going to be the dominant hemisphere. Dominant hemisphere. Okay. Whenever your dominant hemisphere is getting involved, a patient is not able to read, write, calculate, not able to differentiate the fingers, and right and left confusion is there. What is this called as? Who is the dominant man? Very good. He is going to be our Gerstmann syndrome. Gerstmann syndrome. Gerstmann syndrome, where the lesion is in angular gyrus, where a patient is not able to read, write, calculate, understand the fingers, and right to left differentiation. Okay. One more question from here I'm going to ask you. If this area is involved, what kind of aphasia patient can develop? What kind of aphasia patient can develop? Very good. It is going to be called as anomic aphasia or nominal aphasia. Nominal aphasia. Okay, anomic aphasia or nominal aphasia. Excellent. Okay, now imagine another patient is coming to you where a structure in the temporal lobe. In temporal lobe, you have a structure like this, which is getting involved. In temporal lobe, you have a structure like this, which is getting involved. What is bilaterally? It is getting involved. So, you know, I have told you in regular class, I have told you, Padayappa Rajinikanth. Yes, very good. Kluver Bucy syndrome. What he does? He has hyper orality, hyper sexuality, loss of fear, then visual agnosia, amnesia. He forgets who he is. Amnesia. Okay, Mr. Bean character we have seen, right? These are the features of Kluver-Bucy syndrome. Okay, Kluver-Bucy syndrome. So these are the few syndromes I want to tell. Anything more than this I want to tell here? Okay, so a person is going to come to you and this person is not able to recognize his girlfriend. He can recognize the girlfriend's voice, but not the girlfriend. Very good. It is going to be prosopagnosia. So in prosopagnosia, where is the lesion? At the junction of temporo-occipital lobe. Yes, very good. Very good. Excellent. Okay, excellent. So this is about the important things in your brain. Okay. Now we are going to go into the, it's specifically, if you want to tell, it is going to be called as fusiform gyrus. Very good. Fusiform gyrus. Okay, fusiform gyrus. Very good. Very good. Excellent. Okay. So this is about the prosopagnosia. Okay. And we will just go into the next topic. So we know we have the spinal cord here. So our favorite thing is spinal cord. So we'll go into the spinal cord. So, this is going to be the spinal cord. Okay. And this is going to be the gray matter, white matter differentiation. And what tract is here? Posterior column. What posterior column carries? What sensation? VIP sensation. How the fibers are arranged? In the form of SLTC. Okay. Then what we have? We have here our corticospinal tract. How the fibers are arranged? The fibers are arranged in the form of fibers are in the form of CT-LS. Then here we have our spinothalamic tract. We have our spinothalamic tract. How about the fibers are arranged? In the form of CT-LS. Okay, CT-LS, right? Now, clear? I hope I'm clear till now, right? Okay. So here, if you take corticospinal tract, it is going to be a descending tract. Posterior column is going to be an ascending tract. Spinothalamic tract is going to be a ascending tract. Okay, where this posterior column fibers will cross. At the part of lower medulla, right? Where this corticospinal tract fibers will cross. Lower medulla. Where this spinothalamic tract fibers will cross. In the spinal cord itself. Excellent, excellent, very good. Okay, very good. Now, imagine a person is coming to you. In this person, he is having loss of VIP and weakness and loss of pain and temperature. So what is this condition called as? Brown-Sequard syndrome. Where is the lesion? Which side the lesion is there? VIP is? What is VIP? Vibration, position, proprioception. Vibration, position, proprioception. So here it is going to be left Brown-Sequard syndrome or hemisection of cord. Right? It is going to be left side at Brown-Sequard syndrome, or it is going to be your case of hemisection of cord. Clear? Okay. Now, coming to again to your spinal cord. Okay. So here, what is this one? Anterior spinal artery, posterior spinal artery. Okay. And okay. Whenever your anterior spinal artery is getting involved, okay, whenever your anterior spinal artery is getting involved, what is going to happen? Yes, this is a Beck syndrome. Very good. Okay, anterior spinal artery is getting involved. Then the patient is going to have bilateral loss of pain and temperature and bilateral weakness will be there. Weakness will be there. Clear? Also called as Beck syndrome. Whenever your posterior spinal artery is getting involved, posterior spinal artery is getting involved. Posterior spinal artery means it is going to be unilateral or bilateral loss of vibration, position, proprioception. Yes. Um, See, actually, uh, uh, since it's a revision class, the thing is, few things will not be able to elaborate. Okay. So SLTC means we know that fibers are going to be arranged in the spinal cord, which is going to be medial most fibers is sacral fibers and the lateral most fibers is cervical fibers. Okay, lateral most fibers is cervical fibers. Okay, that is going to be your SLTC. Rather, in your corticospinal tract, the medial most fibers is cervical fibers and the lateral most fibers is your sacral fibers. Okay, so based on this only, we are going to tell you what kind of um, uh, weakness is there, whether it's ascending weakness or a descending weakness in intramedullary and extramedullary lesions, right? Okay, yes. So coming to next one is amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is a condition where you are going to have UMN plus LMN involvement in the same patient. Okay, and most commonly it is going to be sporadic, but 10% of cases are going to be familial, and it is due to one mutation called as SOD mutation. What is SOD mutation? Superoxide dismutase 1 mutation. Okay, SOD1 mutation. Okay, so it is going to involve both your upper motor neuron and lower motor neuron. That is going to be called as amyotrophic lateral sclerosis. Okay, amyotrophic lateral sclerosis. Then multiple sclerosis. Multiple sclerosis is demyelination of the white matter of the central nervous system. Okay, it is going to be involving the upper motor neuron fibers. Okay, so the syndrome here you want to know. The syndrome name is, someone has already put in the chat box. It is Beck syndrome. Beck syndrome. Okay, Beck syndrome. Okay, then coming to the next thing. Okay, so the next thing is subacute combined degeneration. Okay, so here we have three differential diagnoses. One is going to be your Friedreich's ataxia. Okay, then subacute combined degeneration, and the next one is going to be your tabes dorsalis. Okay, tabes dorsalis. Okay, tabes dorsalis. Tabes dorsalis. Okay, now whenever you have a patient who is going to have subacute combined degeneration, it is going to involve the posterior column. Okay, whenever posterior column is going to have involve, what is going to happen? Loss of VIP sensation. Okay, next is it is going to involve the corticospinal tract. Okay, whenever corticospinal tract is getting involved, then patient is going to have weakness. Whenever there is a weakness, what is going to happen? Plantar extensor. Okay, then he is going to have involvement of spinocerebellar tract. Whenever it is getting involved, what is going to happen? PSA. PSA has no syndrome. PSA has no syndrome. Only ASA has a syndrome named called Beck syndrome. Okay, spinocerebellar tract is getting involved, then the patient is going to have ataxia plus peripheral neuropathy. Because of peripheral neuropathy, there is going to be diminished or absent reflex. So this is going to be a feature seen in patients with your okay, and spinocerebellar tract is involvement is little rare here. Okay, if you take the cardinal feature is going to be these three things: posterior column, corticospinal tract. Okay, whenever your spinocerebellar tract is getting involved, then it is more specifically seen in Friedreich's ataxia. Friedreich's ataxia. Okay, then if you see the tabes dorsalis or neurosyphilis, where there is going to be involvement of posterior column, okay, and peripheral nerve. Okay, because of that, patient is going to have loss of VIP, and patient is going to have loss of DTR. Okay. Then poliomyelitis is going to be having involving the anterior horn cell. Because of the involvement of the anterior horn cell, what is going to happen? Patient is going to have a flaccid paralysis. Okay, flaccid paralysis. Flaccid paralysis. Okay. And here again, patient is going to have Romberg sign positive. Romberg's positive. Okay. Then syringomyelia. Syringomyelia is called as central cord syndrome. So if this is the spinal cord, this is going to be the gray matter. This is the central canal. Okay. Now what is going to happen? It is going to involve the crossing fibers of spinothalamic tract. Crossing fibers of spinothalamic tract. So whenever this is going to involve the crossing fibers of spinothalamic tract, whenever it is going to involve the crossing fibers of spinothalamic tract, what is going to happen? The patient is going to have more commonly involvement of CAT1 region. Whenever CAT1 region is going to have involved, what is going to happen? It is going to be involving the spinothalamic tract. Because of this, what is going to happen? The patient is going to have painless burns. Right? And what sign you are going to get? You are going to get cape distribution or shawl sign. What is this classical what to say, anesthesia called as here? What is the anesthesia? Very good. It is called as dissociative anesthesia. Very good. Very good. Okay. And which condition it is associated with? It is associated with Arnold-Chiari malformation. And if this is going to be turning out to be a syringobulbia, what involvement will be there? What kind of? Very good. It is going to be onion peel pattern, where initially it is going to be the outermost part of the face, middle part of the face, and the inner part of the face is getting involved. Inner part of the face is getting involved. Okay. So it is because of the fifth nerve compression, syringobulbia. Right? Yeah, very good. Balaclava helmet or degerine distribution. I have told you. Balaclava or degerine distribution. So with this grossly, we have tried to cover the whole spinal cord. Now we are going towards the end of your spinal cord. What is the end of the spinal cord called as? Conus medullaris versus cauda equina. Yes? Okay. Now, your spinal cord extends from C1 vertebra and it ends at the level of L1, L2 vertebra. When the spinal cord, see, SACD is subacute combined degeneration, right? Subacute combined degeneration. In subacute combined degeneration, what is going to happen is it is going to involve posterior column, corticospinal tract, okay, and rarely, very rare to get involvement of spinocerebellar tract. If spinocerebellar tract is getting involved, then it is going to be more of Friedreich's ataxia. Friedreich's ataxia. Okay. Now, Friedreich's ataxia. Whenever posterior column is getting involved, there is going to be loss of VIP. Right? Corticospinal tract is getting involved. Okay. Corticospinal tract is getting involved means whenever corticospinal tract is getting involved, how will be the reflex? Reflex will be exaggerated. Okay. But here the peripheral nerve is getting involved. Because of that, what is going to happen? There is going to be absent or diminished DTR. Absent or diminished DTR. Okay. Rather, in corticospinal tract involvement, how will be the plantar reflex? Plantar reflex will be extensor. So whenever they ask you in any question, a patient comes with absent DTR with exaggerated plantar reflex, what will be your answer? What will be your answer? It will be SACD. Okay. So shawl sign, which area of your body supplies T8 and T1 supplies which part of your body? It is going to be your hands, right? So whenever you put a shawl, the shawl will be extending like this, right? So all through this area, you are going to have loss of pain and temperature, and that is going to be called as shawl sign. Clear? Hope I'm clear till now. Yes. Coming to this, your spinal cord ends at this level, and this part is called as conus medullaris. Okay. Conus medullaris is the part where the fibers are going to start come like this, and then it is going to exit like this. Okay. So it is going to contain both UMN fibers and LMN fibers. Rather, below the level of in TAB is only posterior column and peripheral nerve is getting involved, and corticospinal tract can also be involved. Okay, but it is little uncommon. So it is going to involve more of posterior column and peripheral nerve. Tabes dorsalis, posterior column and peripheral nerve. Okay, so here in cauda equina, what is going to happen? Cauda equina is going to be involving the fibers which are below level of conus medullaris. Okay, so if you take here, the conus medullaris is going to have fibers from S2 to S5. Okay, if you take the cauda equina, the fibers are from L2 to S1. L2 to S1. Okay, here it is going to be UMN plus LMN. Here it is going to be LMN. Okay, okay. Which part of your vertebral body is getting involved here? So this is going to be at the end of spinal cord, right? So it is going to be involving this part. So it is going to be T12 to L2. Here it is below the level of L2 vertebra. This is vertebra. Don't confuse. Vertebra. Very, very important. What is the cause? In both the conditions, it is going to be either a tumor, trauma, or compression. Yes, I hope clear. Okay, so this is going to be conus medullaris and cauda equina. Okay, now coming to the difference between conus medullaris and cauda equina, if you take conus medullaris, it is going to be a mass sitting here, right? Mass sitting here. So whenever the mass sits here, it is going to compress on both the sides. So it is going to be bilateral. Rather, cauda equina is going to be a cut below. So it is going to be unilateral, more common than bilateral. Unilateral, more common than bilateral. Then conus medullaris is going to have symmetrical motor weakness. But as I told you, the motor involvement, whenever the fibers from S2 to S5 is getting involved, it is going to be very unlikely. Okay, and cauda equina is going to be asymmetrical involvement. Okay, asymmetrical involvement. Sensory involvement. Sensory involvement. Whenever sensory involvement is there, it is going to be involving the perianal area. What is this anesthesia called as? What is this anesthesia called as? This is called as saddle anesthesia. Okay, and here it is asymmetrical involvement. Okay, so here saddle is not so common, but saddle can be there whenever it is a very deep compression. Whenever it is a very deep compression, then it is going to be involving the saddle. Okay, involving the saddle. Okay, so this is very, very important. Okay, very, very important. Then Next is reflexes. So I told you below S2, there is no root value for deep tendon reflex. Ankle ends with S1. So here it is going to be in having reflexes. Deep tendon reflexes are going to be, DTR is going to be normal. Okay. Here it is going to be an LMN lesion. So DTR will be absent. Okay. Since it is a UMN plus LMN, at the level of lesion, it is going to be an LMN weakness. Below the level of lesion, it is going to be a UMN weakness. Okay, UMN weakness. And here it is going to be a UMN, LMN weakness as a whole. LMN weakness as a whole. Okay, then impotence. Impotence means I told S2, S3, S4, S5 is going to be the root value for sphincters. Okay, so sphincters means it is going to cause early sphincter involvement. So patient is going to have both urinary and fecal incontinence, and S2, S3, S4 is going to supply the sphincteral area and the prepusal area. So it is going to cause impotence. Okay, but this is uncommon here. Uncommon here. Then, whenever the patient is having involvement of vertebral column, okay, then patient can have radicular pain. So radicular pain can occur in this condition, cauda equina, more commonly than conus medullaris, but it is can be seen in both the conditions. Okay, so back pain also can be seen in both the conditions. Okay, but when you will get radicular pain, in which kind of compression? Radicular pain, in which kind of compression you will get radicular pain and back pain? It is extra medullary compression. Right? Okay, extramedullary compression. So we have discussed this in extramedullary and intramedullary differences, right? Extramedullary and intramedullary difference. Okay, so these are the few things about the spinal cord. Okay, so we have finished spinal cord. We will go into the next topic. Okay, next topic. Now, coming to seizures. Okay, yeah, in IMT it is going to be funicular pain. Very good, very good. Okay, so whenever we are going to discuss about seizure here, okay, so seizure is going to be a very, very important topic. Okay, so we know seizures. Okay, we have three definitions here: seizures, epilepsy, convulsions. What is seizure? Seizure is abnormal, excessive, hypersynchronous neuronal activity of brain. Abnormal, excessive, synchronous, hypersynchronous neuronal activity of brain. Epilepsy. What is epilepsy? Whenever you have more than 2 unprovoked seizures. Right? What is convulsion? With motor activity. Seizure with motor activity. Yes? Now, seizures, according to International League of Epilepsy Association, you are going to divide your seizures into 2 types of seizures: focal seizures and generalized seizures. Focal seizures can be further divided into dyscognitive seizure and non-dyscognitive seizure. Abnormal, excessive, synchronous or hypersynchronous neuronal activity of brain. It's just definition. Okay, so we have discussed in our regular class what is seizure and how to differentiate seizure from other terminology. Seizure is abnormal, excessive, synchronous or hypersynchronous neuronal activity of the brain. Okay, that is called as seizures. Okay, so seizure, it's just a definition. Okay.